This webinar is being recorded, and we will have the audio and video available in the YouTube channel of the RHSC. In a day or so, we will share the link to the recording. Please do not hesitate to contact Laura Mayer or myself if you have any problems during the webinar. The LEAP report is a way to estimate future use and cost of reproductive health supplies in 4 key health areas: contraception, menstrual hygiene, abortion and post-abortion care, and maternal health. Today, we will be focusing on maternal health, and the LEAP report has its origins in the historic contraceptive gap analysis, but it has made quite a leap into new health areas. And this is why we now have a lot of information for the maternal health community. What is LEAP? This is the 24th year of providing data. And this new version of the commodity gap analysis provides a separate gross national income comparison report. It has new future scenarios, a new category of menstrual health product use, new data sources to better capture cost comparisons of medical abortions, a more probing maternal health analysis asking what happens if more women use multiple micronutrient supplements, MMS, and emerging maternal health products. We will also see a country regional comparison, a data explorer, a product deep dive data explorer, and I hope that with this very short description, I've encouraged all of you to check on the LEAP report. I'll put a link to the report in the chat. So now I'll pass the baton to our MHS caucus co-chair, Andrew Story from CHAI. The microphone's yours, Andrew.
Thanks, Milka. And hi, everyone. I'll keep this very short. Just a quick notice, first of all. Thank you to everyone who's volunteering for the nominating committee to search for the new chair of this caucus. And my thanks to everyone involved in this. Also, please be aware that nominations for the new chair are now open, and I would strongly encourage everyone on this call to consider applying. It's a great role. It's a great opportunity to be involved in this important grouping, and I strongly recommend that. Moving on, the LEAP report, Milka's already done the introduction for me. Thank you, Milka. So just to quickly say, we're fortunately joined today by Michelle Weinberger and Rachel Sanders, both from Avenir Health. They will be presenting on the maternal health product findings now. And I'll pass to them. Thank you very much.
Great. Thank you, Milka and Andrew, for that introduction. So our plan today is to give a brief introduction of the LEAP report overall, to then look at some key findings from the maternal health report. We're going to spend a little time looking at what LEAP tells us about variation that we see across both income groups and regions. Then we're going to show these 2 new data explorer tools that allow you to have more access to the data. And then finally, we're going to save some time at the end for questions and answers and discussions. If you do have questions as we're presenting, please just put them in the chat. And as Milka noted, we'll get to them at the end. We're also going to be using Mentimeter today just a little bit to get some more engagement from the group. And there is a QR code on this slide, and there is also a link in the chat that Milka just put in. So with that, moving on to the LEAP introduction. But before we get to the introduction, we wanted to do a quick Mentimeter just to sort of get a sense from those on the call today of your familiarity with the LEAP report. So the Maternal Health LEAP report first came out in 2021. So we've had a couple of years of it being out and now updated with this 2024 report. And so just wanted to get an understanding. So I see some votes coming in. So you have a few people who have used the reports, lots of people who are familiar but haven't really explored them in detail, and someone who is unfamiliar. So we hope this morning or this afternoon, depending where you are, session will be useful in kind of building your understanding of what is there and helping you see how you can access this data so it can be more of a resource for this community going forward. So LEAP covers 4 areas, as Milka mentioned: contraception, menstrual health, abortion impact, and maternal health. And while the results for each of these are presented as sort of 4 independent reports, in the background of the LEAP analysis, the analyses are interconnected. So for example, changes in contraceptive use influence unintended pregnancy, which has an impact on need for abortion impact and maternal health services. And changes in what methods women are using, namely increases in hormonal contraceptive use, have an effect on menstrual health products through changes in bleeding and what that means for use of menstrual health products. We also have interplays between the maternal health and the menstrual health product use by accounting for women who are pregnant and postpartum not needing menstrual health products. So we have lots of interconnections in the back end of what's happening in our analyses. Across all of the reports, we present the same types of findings. First, we look at the people who are needing and using key reproductive health supplies. We look at the quantities of drugs and supplies that are used, and then the costs of those drugs and supplies. We look at this at a current landscape, which for this LEAP report is built on 2023. And then we project forward 3 different future scenarios to explore changes out to 2035. Our focus is on 132 low-income countries, and we often, as you'll see this morning, present results aggregated by income group of lower income, lower middle income, and upper middle income countries as defined by World Bank. We use a wide range of data sources to create the LEAP analysis, as you can see on the slide here. So we have population projections coming from the UN Population Division. We get a lot of information out of household surveys, such as DHS, mix, and PMA surveys. We draw on a variety of different sources for data on price and sales volume, as well as other research and existing models for other key model inputs. And I would say this is especially true for maternal health because we're needing to understand the share of women who are in need of different maternal health products. All of the sources that are in yellow on this graphic indicate new data sources for this LEAP report, and other data sources have been updated where new data was available. For example, picking up new surveys, or getting more recent data from other data sources. So for those who were familiar with the previous maternal health report, these are just a few specific updates we wanted to highlight of changes that were done for maternal health. So we extended projections out to 2035. We found some newer and updated sources to help estimate both coverage and burden. This year, we introduced a new product, multiple micronutrient supplementation, and we'll talk a little bit more about what that looks like in the results. And we also adjusted our scale-up scenarios based on feedback from members of this caucus and others in the community who we consulted during the update of LEAP to be able to make sure that our scenarios sort of represent ambitious yet realistic changes that could happen in the future. We also restructured the report to make the data more accessible. So now this year for each health area, there are 2 main reports. There is an overview report that is a dynamic report for any selected region. We do, for some other health areas, have results available by country, but for abortion impact and maternal health, at this time, we're only publishing regional results. So this report, you can select any region from a drop-down list, and the report updates to be able to kind of have a custom report for that selected region. And then second, we have a global GNI comparison report that focuses on differences between lower middle, and upper middle income countries. We then have these two data explorer tools, which Rachel will showcase for us later on this webinar. And then for those who just want the numbers to do their own analysis, we have an annex of key data tables available for any selected region. And you can also download all of the data into an Excel file. So with that, I will pass over to Rachel to talk us through some overview results.
Great, thank you, Michelle. I'm going to take us through first some of the highlights at the aggregate level. So these are findings that you'll find in the overview report primarily. Then we'll take a bit of a more granular look at variation by region and by income level. And then we'll move on to showing you how you yourselves can use the data deep dive options to look at comparisons that you might find most interesting for your work. Next slide, please. Okay, thanks. So as Michelle mentioned, we have approached this analysis in an integrated manner. So starting from the world population prospects estimates, we then introduce all the elements around contraception, around abortion and post-abortion care, and then use that to produce estimates of numbers of pregnancies and births that would feed into each of the different areas of analysis. So that provides our point of departure for thinking about populations in need of care for antenatal care supplies and childbirth supplies. When we look at births, we see that from 2023, by 2035, we would have around 3 million more births each year, rising from around 127 million in 2023 to around 130 million by 2035. Next slide, please. So this, we include in this report 7 priority drugs that, if available, would prevent a significant number of deaths. We also include what we call 3 emerging drugs for maternal health. So this choice of drugs was informed by the UN Commission on Life-Saving Commodities for Women and Children, the WHO's list of priority life-saving medicines, the WHO Essential Medicine List, and Results for Development's list of priority maternal health medicines. I mention these because when we start to run this analysis, we initially consider a huge array of medicines that one might consider including and that are important. But in order to provide a coherent and cohesive set of results and focus on those that are most important, narrowed it down to this list based on those documents. So of the 7 priority drugs, 3 have been identified as life-saving maternal health commodities: oxytocin, misoprostol, and magnesium sulfate by the UN Commission on Life-Saving Commodities for Women and Children. We also, as mentioned earlier, include 3 emerging drugs for maternal health. So that's heat-stable carbetocin, tranexamic acid, and multiple micronutrient supplementation, which have been identified as by experts as drugs that are beginning to or already are having an important impact on maternal health. Next slide, please. Before I begin to dig into the results, I just want to set the framework for the analysis because it's a little bit different from some of the other health areas because we consider a case. So the unit for maternal health is defined as a case, which is something which might be approached with a health intervention to prevent, manage, or treat complications during pregnancy and childbirth that uses one of the maternal health drugs under review. So using case as the unit of analysis allows for the fact that one pregnant woman may receive multiple interventions that use the same drug. A case can and will, in most cases, include multiple doses of a drug, and that not everyone who needs an intervention receives it. So we split cases into those that needed but didn't receive a drug, and those that needed and did receive the drug. Coverage, or the percent of people who need an intervention that includes one of those drugs and actually receive it, is used to calculate the numbers of cases which receive and don't receive the needed drugs. So that coverage entry is really the next layer over and above the population estimates and the birth estimates are used to calculate the numbers of cases receiving and not receiving. So just a few highlights from this slide. You can see in this table, there's still a high level of need that's not covered for priority maternal health drugs, ranging from around 42% of cases of eclampsia and preeclampsia that need magnesium sulfate, or 40% to 42% of cases needing infection care that don't get it, on up to newer drugs like TXA, where we don't have great data. That's one of the areas we really hope to see more for the next round. But we, based on what we have found, are estimating that around 5% of cases of PPH where TXA could be used is getting it, leaving 95% uncovered, where people would benefit but aren't receiving it. Next slide, please. The total cost of 7 priority and 2 emerging drugs, so the HSC or heat stable carbetocin and tranexamic acid, is estimated around 216 million in 2023. The largest portion of the costs are for longer term use drugs, such as iron and folic acid and hypertension control with methyldopa, followed by infection treatment with metronidazole. The total cost of the 3 life-saving maternal health commodities, oxytocin, misoprostol, and magnesium sulfate, is around 24.7 million. So this represents just 11% of the total cost of those 9 drugs that I mentioned. And the future scenarios include multiple micronutrient supplementation, and I'll talk a bit more about that in a minute, but this is intended to give you kind of our baseline or our starting point estimates of these maternal health drugs. Next slide, please. So for the 3 scenarios that we present, we generate, as mentioned earlier, projections out to 2035. The first scenario is simply maintaining coverage. So this scenario accounts for changes in the numbers of pregnancies and births and maintains current levels of intervention coverage, by which we mean the share of women needing an intervention that uses one of the 7 maternal health drugs under review. We really see this scenario as providing a baseline for comparison and not where we anticipate or hope that the field will go. Scenario 2 includes increased coverage and a moderate shift in drug use. So this scenario accounts for the same change in the number of pregnancies and births as seen in scenario 1, and also increases coverage of the included interventions and facility delivery to reach the coverage in the next highest income group by the final year. So in this scenario, we also account for some shifts, some moderate shifts in which drugs are used. So we assume that heat stable carbetocin will increase from 5% of cases receiving uterotonics for postpartum hemorrhage prevention during facility births to 15% by 2035, thus reducing the use of other uterotonics. Tranexamic acid is similarly assumed to increase from 5% to 15% by 2035, in addition to the other uterotonics. And misoprostol for PPH prevention and treatment among home births is assumed to increase from 5% to 15% by 2035. Last but not least, our scenario 3 is a much more ambitious scenario, which includes increased coverage and what we might call sizable drug shifts. So again, this scenario incorporates the same numbers of pregnancies and births as the other scenarios, the same increase in coverage and facility delivery as scenario 2, but also includes a sizable shift in which drugs are used. So we assume that heat stable carbetocin, tranexamic acid, and multiple micronutrient supplementation will be used for 50% of cases which receive the care by 2035. So we're substantially shifting, for example, uterotonics to heat stable carbetocin for prevention. We're assuming much higher coverage of tranexamic acid and a substantial shift from iron and folic acid only to multiple micronutrient supplementation. which would obviously then reduce the use of iron and folic acid for non-anemic women. All right, next slide, please. So as seen on this slide, based on those scenarios, we would see pretty substantial differences in cases receiving drugs over time and across the different scenarios. So I'd encourage everyone to take some time to dig into the report. This area, because of the numbers of drugs included, has a great deal of complexity that I was told I could not have 2 hours of everyone's day to cover. So we're just going to cover some highlights today, but I would encourage everybody, again, to take some time with the report because I think it can be really interesting. Again, some highlights are for iron and folic acid with an increase in coverage, which is again our scenario 2, there'd be a substantial increase in cases covered from 47.6 to 71.6 million by 2035, which is about a 50% increase. With an increase in coverage and a sizable shift in drug use, again, our scenario 3, you're going to see a modest decrease in cases receiving iron and folic acid because half of the women receiving that supplementation would shift to multiple micronutrient supplementation in this scenario. So in this scenario, you'd also have 35.8 million cases receiving multiple micronutrient supplementation. For oxytocin, we see that the number of cases in lower and middle income countries in scenario 1 would see just a, stay around 70 million. Again, that's you're maintaining coverage. But with an increase in coverage and a moderate shift in the use of heat-stable carbetocin for hemorrhage prevention in scenario 2, you'd see an increase to 97.7 million cases in 2035. With an increase in coverage and the shift to heat-stable carbetocin, you'd see a little bit of a decrease in the use of oxytocin by 2035, but a scale up of heat-stable carbetocin. If we look at tranexamic acid, if we look at scenario 2, you can see there'd be an increase to around 2 million cases of postpartum hemorrhage getting TXA or tranexamic acid. And with an increase in coverage and the shift in drug use, we'd assume that around 7 million cases would receive tranexamic acid by 2035. One point I should make that'll give you a little explainer on this slide is that for antihypertensives, for magnesium sulfate, and for metronidazole, scenarios 2 and 3 don't differ because in both of those scenarios, the drugs see the same increase in coverage. And so thus you have the same numbers of cases. So just a reminder that scenario 3 really brings in that drug shift for those interventions where we have multiple options of drugs included in this amount. So if we look at the costs associated with those scenarios, you can see that there's limited cost increases seen in scenario 1, around 1%, and that's just driven by the numbers of pregnancies and births because we maintain coverage. So again, this is our counterfactual. We do see a pretty substantial cost increase associated with the coverage increases and the very moderate drug shifts seen in scenario 2. So an increase of around 65% by 2035, going up to 357 million. And if we also bring in that additional, the drug shift, bringing in more multiple micronutrient supplementation and heat-stable carbetocin and aggressive scale-up of TXA, then we would have a 107% increase to 448 million by 2035. So I do want to note that these results reflect the current unit prices of all drugs. So we know that prices may change in the future, particularly as the markets of the 3 emerging drugs, heat-stable carbetocin, tranexamic acid, and multiple micronutrient supplementation, further develop. Additionally, there is some evidence from a limited number of countries that indicates that actual practice may involve additional dosing beyond the guidelines. to reflect challenges in quality of the drugs. So those are two areas that we hope more evidence will become available such that future iterations of the LEAP analysis can reflect them. But at this time, we don't feel that there's sufficient data to model those elements. So this reflects what we might call a normative approach and a current year value approach for the drugs. Next slide, please. All right, so just a reminder that changes in cost for each drug are going to reflect coverage, they're going to reflect demographic influences, and they're going to reflect the drugs in use. So as you look at each of these graphs, keep that in mind. Just a few highlights that I want to draw everyone's attention to. The cost of iron and folic acid, for example, in scenario 2, would see a pretty substantial increase to 151 million by 2035. But when we look at the increase in coverage and a substantial shift in drug use in scenario 3, you'd actually see a bit of a drop for iron and folic acid to 75 million as we bring in multiple micronutrient supplementation, which would reach around 144 million by 2035. And so for that reason, sometimes in the, in the reporting, you'll see that we group usage. So you can see that supplementation together comes to a little over 200 million when you think about a distribution across iron and folic acid and multiple micronutrient supplementation under that third scenario. Focusing in on the 3 life-saving maternal health commodities, magnesium sulfate, oxytocin, and misoprostol under scenario 2. These would see a modest increase to costs, around 34 million. And under scenario 3, again, which includes those increases in coverage and drug shifts, there would be an increase to 29 million. And so that includes the substitution effect of heat stable carbitose. So these are just a few of the overview findings. At this point, we're going to talk more about the variation between regions and income levels with Michelle, and then I'll take you through some of the opportunities to dig deeper in the reports that are available to you.
Great,
Over to
thanks.
you.
Thanks, Rachel. So as Rachel said, those findings she just presented are the totals across all low and middle income countries. And we know that those aggregate totals hide lots of variation. And so just wanted to take a little bit of time to look into some of that variation, both across income groups, so that's low, lower middle, and upper middle income countries, and across different geographic regions. So we find that there's substantial variation in the cases that need and receive care across income groups. We generally see a pattern that coverage, so the share of cases that receive the needed drug, is lowest in lower middle income countries and increases as we go to lower middle and upper middle income countries, which you can see quite clearly here. For drugs needing treatment of maternal health infection in the first graph, and drugs that need and or cases that need and receive drugs for preeclampsia and eclampsia treatment in the second graph. I will say we don't have time this morning to look at all of the different drugs, but this pattern varies some across different drugs. So it's not always quite as stark of a shift as we see for these two. And while not reflected in this graph, we also see differences in the share of cases that need the drugs based on some regional differences that we see in the data of some of these maternal health outcomes, and therefore the need for some of these drugs. If we look at costs across income groups, we see in absolute terms that the most costs come from lower middle income countries, and this is due to the number of births in lower middle income countries, as well as coverage in those countries, so largely different by that demographic influence. And we can also see, if you look at sort of the bars split across the different interventions or the different drugs, we can see some differences in the share of drug costs across different regions. So with metronidazole playing a larger proportional share in lower middle and upper middle income countries than it does for low income countries, for example. Not only do we see differences in where countries are now, but we also see differences in the future. So if we look at the total costs of the 7 priority and 3 emerging maternal health drugs across our 3 scenarios, we see variation in growth. And this is due to a couple of things. This is due to differences in demographics across the 3 income groups. So in terms of how rapidly we see changes in births influenced by fertility rates, this is due to differences in the change in coverage that we see in scenarios 2 and scenarios 3. So here we're just highlighting results from our 3rd scenario of increasing coverage coupled with a sizable shift in drug use. And we see that in relative terms, the largest change is in low-income countries with a 185% increase in costs under this scenario. But the largest change in absolute terms is seen in lower middle-income countries with a 101 million increase, but a much more modest difference in terms of the relative change at just 83%. We also see differences across regions, and we'll explore a little bit more how you guys can get access to this regional data. So here we're looking at the share of cases that need and receive uterotonic drugs. And we can see large variations in the share that receive these drugs, or I guess you can look at this on the flip side of the share that needed the drugs and don't receive them. So we see sub-Saharan Africa has the largest share of cases that needed these drugs but didn't receive them at nearly 70%. This value is only 34% for Latin America and the Caribbean and 29% in Europe and Central Asia. So again, lots of different variation in this across different drug needs, different kind of categories of drug needs and different regions, but just to remind ourselves that there is a lot of variation. And so we want to not just look at these aggregate numbers, but explore some of this variation to better understand the implications of that. And then finally, we also see variation in the cost of drugs across different regions, and this is driven by differences in coverage, differences in need, and differences in the number of births. So here we can see under scenario 3, the cost of heat-stable carbetocin in 2023, 2029, and 2035 across the different regions. So we see a very high cost in sub-Saharan Africa compared to a lower cost, say, in Europe and Central Asia. So with that, I will pass back over to Rachel, who is going to walk us through our 2 Data Explorer tools, which will allow you all to dig more into these regional differences.
Great, thanks, Michelle. If you can go ahead and go to the next slide. So as Michelle mentioned earlier in the presentation, there are 2 new tools that were just released with the LEAP 2024 report. And that includes a regional comparison data explorer, which lets you explore the estimates of the number and types of services, as well as supply costs in the region that you've selected, as well as the product deep dive data explorer, which gives you a detailed pictures of the quantities and the costs for the product which you have selected. Next slide. If we look at the regional comparison explorer, you can use the drop-down list to select the grouping of interest. So the World Bank regions, as most people probably know, are aggregated at a higher level, and UNDP regions are more detailed. Next slide. And you can move back and forth, of course. So like you have that flexibility. You can also interact with the figure to explore the data in different ways. So in this example on maternal health services, we're showing the cases that need and receive drugs for preeclampsia and eclampsia treatment by the World Bank region. You can see that in this case, the largest absolute number of cases needing and receiving care is in Sub-Saharan Africa and East Asia and Pacific, with the largest number of uncovered cases in Sub-Saharan Africa. So if you look at the bottom right of the screen, you can see that I've made the selection of looking at absolute numbers. You can toggle back and forth between absolute and relative to understand absolute numbers and proportions by region. Next slide. You also have the ability to switch back and forth between cases and costs. So in this case, I've further shifted. I'm showing the relative distribution of cases that need and receive magnesium sulfate for preeclampsia and eclampsia. You also have the opportunity to shift to costs, which then obviously brings in the unit prices for each of those cases. Next slide, please. You can see here, I move to costs. It's in an absolute number, and you, at this point, also, once you've configured the graphic as you wish to see it or present it to a policymaker or a colleague, you can download it as a CSV for the numbers, or download as a PNG so that you can just pop it into a presentation or a report as you wish. Next slide, please. All right. So if you look at the report as well, you also have the ability to select costs or cases as an indicator, drugs, and scenario. So in this image, this example image, you can see that I'm looking at scenario 3 for heat stable carbetocin, and I've selected costs, and you can see the changes over time for that scenario. So again, this just lets you kind of drill down much more granularly on the results for the scenarios as they're structured in this analysis. And get a sense of what the implications might be over time for that indicator for that drug. So if you could go to the next slide, please. You can also kind of shift that perspective and look at costs or cases by drug for the different regions. And then you can see in this graphic that it then shows you the scenarios results as the presentation point for that particular element that you've selected, either costs or cases. So I think that you've probably seen that there is a great deal of granularity in this set of reports. And so I'd encourage everybody to take a look. We are here if you have further questions or want some support while you explore the data, or to dig into some of the decisions around how this analysis was structured or sources that may not be laid out in the reader's guide. So I just want to thank everybody for taking the time to follow along on this deep dive. And I think I'm going to pass back to Michelle, and then we will have time for Q&A. Oh,
Do you want to
apologies.
quickly, look at the product deep dive?
Yeah, there is a additional product deep dive where you can look at the results by region for each of the products under examination. And again, you have the opportunity to look at quantities or costs. In this example, I'm going to look at magnesium sulfate and at heat stable carbetocin in the images that you'll see. So again, you select the indicator at the bottom left, and either quantities or costs are available, and you can see the future scenario projections by in this case, by income level, and for the selected drug. And you can also look at the product distribution by income group. So in this case, we're looking at commodities again for magnesium sulfate in our example. So the accessibility is very high. You can customize the overview report for any region. You can access the results via these data explorer tools, and all of the graphics can be downloaded as a PNG file for the image, or you can get the underlying data as a CSV file. We've also got key annex tables that provide summaries of the results for any region. And the entire data set can also be downloaded for further analysis. So you can get these results from the Maternal Health homepage, and I think they're pretty clearly labeled. I'm going to go ahead and just jump to a question that came through on the chat. What's the cost for each drug that was used, and how was it calculated? we relied on the UNICEF supply catalogs for the unit prices, understanding that there's a range of procurement prices for each country and for each year. Let's see, and I think Michelle is showing us the next Menti question. If we can ask everybody to please do a little bit of thinking about how you might use LEAP, because this helps us again to ensure that the analysis that's provided is adequate and fit for purpose for the needs that this group's members might have.
Great. So we'll give everyone just a minute or two to respond on the Menti, and then please also be thinking about any questions or things you would like to discuss. So we've got about 15 minutes left for some Q&A and discussion.
And I would encourage participants to, I see we've got some people starting to enter things in the chat for other purposes. So I'd encourage people to both respond to the uses we've suggested we understand people are doing, as well as others.
Thank you so much, Michelle and Rachel. We will have now our co-chair, Siobhan Perkins, who will be leading us through the questions. Siobhan, thank you so much for being here.
Sure. Thanks, Milka. And thanks, to you, Michelle and Rachel, for giving such a comprehensive and, interesting overview of this report. So I'm happy to facilitate any questions. I know, Jeff Jacobs, you had a question in the chat about understanding the total cost. I'm not sure if Rachel answered that sufficiently for you about how they're using kind of a normative approach here, but I think it is recognized that there needs to be some more data kind of on the doses that are actually administered versus that recommendation. So I think for some products that's very specific and required.
Yeah, no, I appreciate the answer. I understand the answer to Rachel's point. I think we understand that there is an underestimate because we know that providers are doubling, tripling the dose of different things or lower dosing of what's recommended.
So I would say we also have uncertainty on unit prices, and we know that there are some countries that are procuring at well below what we're using, and others that might be higher. So I think there's kind of an unknown directionality in some of our estimation.
And I would add to that there's potentially correspondence, lower prices, lower quality, more dosing over and above the recommended guidance.
Mm-hmm. Right. I see we have another question in the chat from Manuel regarding the financing, and if you have disaggregated data on domestic versus external donor funding of these products. Do you all have that data?
It's a great question. Oh, go ahead, Michelle.
We do not. So for those who are familiar with the contraception report, we do a lot of disaggregation between where people go, right? So public versus private sector services. For maternal health, we do not, because there's just such a limitation of data to be able to understand that, right? So for contraception, there's a lot of centralized donor procurement and a lot of availability of that data. We also have a lot more just information about kind of the role of the private sector as a service provider, as well as, from a financing perspective. For many of these drugs where governments are procuring them, that procurement is very decentralized. So you don't have that same centralized role of donors in these markets. And so we just haven't been able to get that visibility. But I think there's a general assumption that in a lot of contexts that, there is a large role of domestic governments in funding these, but recognize that in some settings, women are purchasing these drugs, right, in the private sector and then bringing them or having them used in medical settings. But we just, have
particularly around supplementation, there's an assumption that there's probably more private procurement. For others, there's less information. So it's a great question. It's something that I think there's a desire, particularly with the emphasis around, for example, the postpartum hemorrhage bundle. I think there's going to be more investigation, and we'll have more data the next time we present this set of information to you.
But I would say we have a pretty good sense that donor funding is very limited. You get some small donor procurements that are mostly kind of either in very specific settings, like for refugee settings or things like that, or in kind of emergency settings where donors step in. But we have not seen any evidence and spent a lot of time looking at of any kind of systematic role of donors in procuring these drugs. But would love to hear from those on this group what their perspectives are as well.
Great, thanks. Jeff and Shruti, I see you have your hand up. Jeff, why don't you go ahead first, and then we'll go over to you, Shruti.
Sure. Just a few comments. Really appreciate the opportunity to engage. Really great work. The first one on magnesium sulfate. I do think the SRH, the HRP team at WHO would love to have a conversation with you guys on your coverage rates and the methodology on how you got to coverage on magnesium sulfate. They're doing some work, some clinical trial work right now, and it's a coverage related trial and a vision of broadening coverage. So I think it would be really good if you guys could engage with them directly. We had a conversation with them about a week ago, and I would say it feels like there's some divergence in what they were talking about versus what you guys are showing. So I think it'd be good to have that conversation. The thing that challenges me a little bit is, I appreciate the way you guys have structured this. My question is, as you go from medicine, you go from price, you go to coverage, what about outcomes, right? I mean, you're getting better coverage, or are we getting better outcomes by better coverage? If we're not addressing quality, or even if we get better coverage, are we getting better outcomes? I do think there's an opportunity to take this to the next level of outcomes based on coverage with quality, etc. Might be beyond your mandate, but I do think outcomes is an important element for decision makers to think about. Over.
Yeah, I hear that. Up till now, we've sort of seen that as outside the mandate of LEAP. There's lots of other work and modeling work trying to look at outcomes. I think it's something we can continue to discuss about, if there's room to bring that into the mandate. I think there's lots of considerations around what that would mean in terms of scope, but then also thinking about just introducing another set of assumptions, especially around tackling the piece of quality, right? I think we hear that the community is really interested in being able to say more about that, but ensuring that we had sufficient evidence to be able to speak to differential outcomes for different quality, and then having information to make some assessment about what share of cases are receiving high quality drugs, to be able to then talk about potential differential outcomes. So hear that that's very important, and especially from an advocacy perspective. But I think we need to continue discussing what might be feasible and in scope for LEAP.
Thanks for the response, Michelle. You may have seen, we've started to try to address some of this by doing some modeling work through the University of North Carolina. So there is a paper for the moment, and I'll put it in the chat in a second, looking at the cost of poor quality uterotonics in Ghana. And there's another paper coming specific to Nigeria that tries to model that out. And you'll see some scenarios that may be helpful. Over.
Great, thank you. If I could just chime in before Shruti and Tama take us forward. Your first point about the divergence between our coverage assumptions in these scenarios and the WHO team's assumptions, we had a kind of broad structure in which we assumed that each of the income groups would move to the next income group's coverage by 2035. So that also assumes upstream care is happening. So we're seeing people we're identifying people with hypertension, et cetera. And so it would be great to talk to them. I acknowledge upfront that our kind of scenario structure around coverage change might be different than a team that is looking very granularly at each country's potential for expansion. But well, I appreciate the making of the connection.
I can make
And
the
then-
connection if you need to, Rachel, to specific people who are dealing with it, if you'd like. Just let me
Okay,
know.
sure, that'd be great. And then your second point around the extension of reaching patients or clients and extending that into impact. It is definitely important. And we, as you know, the tools that we're using like LIST do also include impact analysis. But the emphasis of this analysis has very much always been on the supplies by definition. And so while I recognize the importance of attaching impact to this type of analysis, it would behoove us to not ignore the many other things that have to be in place in order to deliver high quality care. So not just the high quality drugs, but also the trained providers, the adequate facilities, et cetera. And so I think that if we were to move to that point, we also have to either provide that extension or very much isolate what we're talking about. And so we would take the guidance of the team in terms of whether that's a reasonable assumption that all those elements are in place. But I would hesitate to, for example, say, you know, we have high quality oxytocin, but that ensures that all the other things are there, because I think it is always a systems approach is important to recognize. So thank you for the questions and for sharing the papers and content. Appreciate it. I think Shruti, you are next in line.
Yeah, hi. Thank you, Rachel, for the great presentation. The report is very insightful. Just wanted to understand if in the two scenarios that you spoke about, scenario 2 and 3, the calculation behind 15% and 50% drug shift, is there any specific calculation? Yeah, over.
No, so we had a survey that was shared with this group members, and then we had interpersonal communications with experts in the field thinking about what might be reasonable. We're talking about more than a decade out at this point. So we ended up balancing both issues of feasibility as well as ambition around providing these drugs. So I think one could argue for additional or alternative scenarios. I think as we start to have a little bit more data about scale up and about introduction of these emerging drugs, we'll be able to do a historic trend that gives us a different perspective. But it was essentially a linear increase to reach the targets that had been established by 2035. Did that answer your question?
Yeah, understood. Thank you so much.
Also, maybe just to add, the baseline assumption of 5% coverage really came out of just not having data, but knowing it wasn't zero because there's been some introduction. And so we just sort of anchored it at that 5%, but hope that as more data becomes available, that we can sort of move from this global assumption to having more kind of country-specific actual coverage data.
Yeah,
Great,
that would make sense. Thank you.
Great. And I see we do have a question in the chat, and then perhaps we'll take a look at Jeff's questions, and then Tom, I'll go to you. Jeff, you mentioned that that this is kind of a rather narrow perspective on a few maternal health issues. And his question is, you know, do we expect to expand this focus on other areas of maternal health? I'm not sure, Michelle, if you want to answer that, or Milka, don't want to put you on the spot, or I could take a stab at it too.
Yeah, I mean, so every year before starting the next LEAP, we kind of do a consultation through joining one of the caucus meetings and then an online survey to sort of gauge interest and expansion. I think maternal health is particularly challenging, right? And that you could open the door wide, and I would say even now with the array of drugs that we have, you know, we're probably pushing the limits on what is manageable in terms of just capturing and presenting and having digestible data. So I think it's always going to just need to be a balance between a desire to capture more and keeping the report to something that is feasible and, you know, provides useful messaging. And so right now, where that balance is led us to the list that we have. I mean, we did add MMS this last time around. I see, so maybe linked to the next question around medical devices. We did explore potentially adding drapes this time, and kind of felt we weren't there yet to be able to capture them, but that is something I think we should re-explore again for next year. So I would say, like, yes, there is room to expand scope, but I don't think we can go too broad. And so need some way of being able to put boundaries on what is in scope for this work.
Yeah, agreed. And these are still the most kind of critical products that prevent or treat, you know, the highest maternal deaths. So I think you've narrowed it quite well for this year, and potentially, hopefully, devices will be included in the future. Okay.
And there's also, Siobhan, the question of resources, right? We don't have unlimited resources to expand the report further. So if people are willing to contribute to the inclusion of devices and other products, no, you're more than welcome to help us do some business development here and be able to expand the list of products. We're over the time. It's 10:01 for you, 9:01 for me. And there's only one more question, I think.
Yeah, I'm happy to stay on a minute longer, Tama, if you want to get your question in. I know you had your hand up for a while.
I'll do it very quick. First, thank you so much. This was very insightful. Maybe what are the key takeaways you say from this report compared to last year, for example? Because there's a wealth of great information, but if you were to, like, say there are one or two things to take away, what would that be?
Shall I go first and then you jump in?
Sure.
Yeah. So I think one of my big takeaways is that while these are substantial sums of money, when we look at public health spending writ large, this does not, so shall we say, break the bank. Huge increases in well-being could be achieved with relatively modest investments. And even if we focus in on those 3 life-saving commodities, it's even smaller. So that's my first point that I want people to take away. Second is that there are really opportunities right now. We include these 3 emerging drugs as a recognition that this field is not static, that there are new drugs, even some that are in place for other uses, like tranexamic acid, which can be extended to postpartum hemorrhage, that again can hugely improve the well-being, reduce mortality, etc. And so again, what I think this analysis tells us is, number one, this is an area of investment that we should be encouraging and that we should be putting figures on, because it can feel huge if you don't have an absolute number. That's the first point. And then secondly, that there's still a good deal of variation. So when we look between regions, when we look between income groups, inequity is still highly present. And so I think we should be also focused on how we bring not just incremental increases for the highest group, but bringing areas up that are really underserved. So I appreciate the question. And those would be my big takeaways. Michelle, do you have others that you'd want people to take home?
Yeah, I think those are all great. So would echo those. I would also say maybe just bringing a broader perspective, working across all of the LEAP reports, is I think, there's the maternal health landscape is really unique from the other landscapes. I'd say one, in terms of kind of the size and value of the market. So going back to Rachel's point about sort of the numbers feel big, but maybe manageable if you think about it relative to other things. And then linked to the discussion we had earlier, I think, generally we see that contraception is this very split market between the public and private sector, right? We see that menstrual health is almost entirely private sector, right? You might have tiny little programs for like funding supplies in schools or things like that, but by and large, it's a private sector market. Abortion and PAC is a little bit split, but highly leans private sector. And maternal health, again, we have some limited visibility into really understanding where there is out-of-pocket burden, but by and large, you have this big role of government financing in this space. So I think understanding those uniquenesses of each of these markets and then what that means for what interventions or advocacy looks like, I think is really important.
Those are wonderful takeaways. I would 100% agree, especially with those top 3 life-saving products. A lot of them are life-saving, but I think those critical ones, as you identified, are definitely priority. So thanks, Thelma, for that question. Wonderful. And thank you all for staying. The ones that are still on the line, thank you for staying for a couple minutes over. We appreciate your presenters and also the participation. And thank you very much for taking the time today. Wish you the rest of a good day.
Thank you, everyone.
Thanks,
Great.
everybody.
Thanks,
Thank you.
everyone.